Good afternoon and welcome to the Healthcare Roundtable, sponsored by Consumers for Quality Care and the Latin Chamber of Commerce. There is simply not a single business, not a single family, not a single individual whose life is not impacted by the healthcare system. If you're fortunate enough to be in good health, you're still paying into the system. If healthcare isn't among your life's primary concerns today, it will be tomorrow. Things change rapidly. It's an extraordinary understatement to say that the healthcare system is complex. It's expensive, it is in constant change and motion, and what it will look like just a few years from now is anyone's guess. Nevadans have a lot on their minds these days. Gas prices, inflation, COVID, crime, traffic, and the Raiders. And bodies being pulled out of Lake Mead. But the quality of our healthcare, the cost of our healthcare, and its reliability of our healthcare should be of enormous concern to everyone. The good news is, here in Nevada, we have some truly brilliant and truly dedicated people who lend their experience and expertise to the issue of healthcare every day. So they are committed to improving the health and the healthcare system here in Nevada. And we are extremely fortunate to have several of them here today. Before we get to our panelists, it is my great pleasure to introduce two people whose work formed the basis for today's conversation. Brilliant people. Jim Manley serves on the board of directors of Consumers for Quality Care. Jim is one of the sharpest and most experienced voices on Capitol Hill in terms of policy and communication. He was one of Harry Reid's closest advisors for many years and was deeply involved in the communication and strategy behind the passage of the Affordable Care and Patient Protection Act. Jim, please take a few minutes and give us some insight into the role and mission of CQC.
Thanks, Peter. Glad to be back with you again for the second year in a row. On behalf of my fellow CQC co-chairs, I'm pleased to welcome everyone to this important discussion on how we can improve the healthcare system and give Nevadans some real relief from their major concern, which, as you're about to hear, according to our research, is rising out-of-pocket costs. Consumers for Quality Care is a coalition of patient and healthcare advocates and former policymakers working together to lift up the voices of patients and make sure they're not getting lost in this big extended debate about healthcare that we keep on having in this country. I'd like to thank everyone for joining us this afternoon to share their insights on this critical topic. As you mentioned, I worked for Senator Reid for 6 years. Wasn't always easy, but God, I miss that man all the time. And you know who our pollster was? A guy by the name of Mark Melman, your next guest. As maybe some of you people, folks might appreciate. I'm sure at some point Mark's going to get sick of me telling this joke, but Senator Reid really did not like pollsters. But he did like Mark, or at least tolerated him. And why? Because in 2010, in that incredibly close race, Mark kept on telling Senator Reid that he was going to win, and lo and behold, of course, he did. So we're going to share the findings from new research today by CQC in collaboration with Impact Research and the Melman Group on the state of healthcare in Nevada. Mark's going to dive into the research further, obviously, but it highlights that there is major work to be done to ensure healthcare is affordable, accessible, and high quality, and I look forward to this discussion. As you're all, I'm sure, aware, the Senate passed, it took 16 months, but finally passed the Inflation Reduction Act yesterday. On behalf of my organization, we obviously strongly applaud and endorse extending the pandemic-era premium subsidies for Americans enrolled in the Affordable Health Care Act, what used to be called Obamacare. and the increasing of a $35 cap on insulin for Medicare beneficiaries. But we think that more needs to be done when it comes to the rising cost of copays, deductibles, and other out-of-pocket costs, and we hope that Congress can deal with this in the weeks and months to come. And with that, Peter, I'll kick it back to you and or to Mark.
Great. Thank you so much for that, Jim. So the survey we'll be delving into was conducted by one of the nation's most respected and sought-after pollsters. Mark Mellman is not only CEO of the Mellman Group, but also president of the American Association of Political Consultants. He's the real deal. Mark and his firm have received numerous awards for their strategy work and have counseled some of the most prominent elected officials in the country. Mark, tell us a little bit about the findings and methodology of this poll on the state of healthcare today.
Great. Thank you very much. Pleasure to be with you all and with my friend Jim Manley. And thank you for the kind words. Just to be clear, this poll was done by us and by Impact Research. Statewide poll online of registered voters in Nevada, 600 sample. Interviews for this survey were conducted between June 21 and June 26. And the margin of error is about plus or minus 4 points for the sample as a whole. It's larger for smaller subgroups of the population. Let me start with some of the key findings, then we'll go through some of the background data. But Nevada voters are squarely focused on inflation and rising costs, so lowering out-of-pocket healthcare costs is more important than ever. Overall, we'll find 46% of voters say that inflation and rising costs should be Congress's top priority. 73% agree that the cost of healthcare are going up more than other things they need. And by more than 3-to-1, voters' main concern with healthcare is that out-of-pocket costs are too high. As a result of these high costs, medical debt is widespread. A majority, 50% of voters, have either had their own household finances seriously affected by medical debt or know someone who has. And among those who've had their finances affected, 71% of those say they or someone close to them have had medical bills go into collection. Voters want to see measures to control costs. They think capping the amount that insurers can charge overall or capping deductibles would help most. More than 60% think insurance company caps would do the most to reduce healthcare costs. There's nearly unanimous agreement, 87%. We don't get 87% of people agreeing on much of anything in this country these days, even in the state of Nevada. But 87% of Nevadans agree that it's more important than ever for insurance companies to cover mental health care, but voters struggle to access it. Again, pointing to the lack of insurance coverage as a major barrier keeping people from being able to access it. So reducing healthcare costs continues to be a politically beneficial platform for candidates. This is a hotly contested state, as we all know. More than 7 in 10 voters say that they want a candidate who makes reducing healthcare costs their top priority in the political season. So, as I say, let me go through some of this data specifically. First, among registered voters, Democrats have a 2-point advantage in what we call the generic ballot, just asking people whether they'd vote for the Democrat or the Republican. 39% say they'd vote for the Democrat, 37% for the Republican, 24% potentially persuadable to either side. Of course, independents more likely to be persuadable, but lean slightly to the Republican side. Latino voters, who are obviously very key in Nevada, 40% of the Latino voters saying they're supporting Democratic candidates, 31% Republican candidates, 29% are persuadable. That's not particularly good news for Democrats. When we look at what people are looking for in a candidate, overwhelming majority are more likely to support a candidate who makes reducing healthcare costs a top priority. Overall, 73% say they'd be more likely to support a political candidate who made reducing healthcare costs their top priority. 34% strongly, much more likely to back such a candidate. And that's true for a majority of Democrats. It's true for a majority of independents. It's true for a majority of Republicans. It's true for a majority of Hispanics. All of those segments, in all those segments, majority saying they're more likely to support a political candidate who made reducing healthcare costs their top priority. As we look at people's evaluations of Nevada's healthcare system, less than half think things are going positively with people having access to affordable healthcare in Nevada. 47% say things are going positively, good or excellent, with people having access to affordable healthcare. But 44% think things are going either not so good or poorly with respect to people having access to affordable healthcare in the state. Overall, we have a similar kind of split in terms of people's assessment of the problems with Nevada's healthcare system. We have a near majority, people fairly evenly divided between saying it has minor problems or no problems at all on the one hand, versus 45% who say it's either got major problems or is in a state of crisis. The biggest issue with the healthcare system, out-of-pocket costs are too high. 35% pick that as the single biggest issue facing the healthcare system in Nevada today. Below that is a pretty sharp fall off. 11% saying too many people lack coverage. 10% saying too many people lack access to mental health services. 10% lack of access to healthcare providers, down into the single digits from there. But 35%, the largest single number by far, say out-of-pocket costs too high, the major problem facing the healthcare system in Nevada. And people struggle most with the high cost of deductibles. 34% say it's the biggest issue for them personally. 27% say that the deductibles have gone up in the last 2 years. Second on this list, premiums that set the monthly amount you pay for health insurance. 30% say that's the biggest issue for them personally. 37% say that's gone up the most in the last 2 years. So more people think that's gone up than anything else, but it's second in terms of what is the biggest issue for them personally. Co-pays next on the list, followed by out-of-pocket prescription drug costs. 22% saying that's the biggest issue for them personally, but 34% saying that's gone up the most in the last 2 years. Who's to blame for high healthcare costs? We ask that on an open-ended basis. The largest number of people by far, as reflected in the size of the words here, insurance companies get the most blame for the high cost of healthcare. People believe that those healthcare costs are going up every year. 81% agree that the amount that they pay for healthcare seems to be going up every year. And if you skip down one below that, you'll see 73% agree the amount I pay for healthcare not only goes up every year, but by even more than other things I need. So 73% saying healthcare costs not only going up every year, but going up by even more than other things I need. In between those two, I feel like insurance companies are nickel and diming me with all kinds of out-of-pocket costs I have to pay. 76% agree with that statement. 61% are telling us at some point they've skipped or delayed going to a doctor or hospital because they are concerned about out-of-pocket costs. 70% say it's impossible for me to know what my costs are going to be because out-of-pocket costs are so unpredictable. So again, large numbers of people, overwhelming numbers of people concerned with the amount that they're paying for healthcare, and again, with the sense that those costs are going up even more than other things that they need. There is a strong consensus that mental health care needs to be covered. 87% take that view. Only 8% disagree. But 59% tell us that it's difficult to find mental health providers that are affordable or covered by insurance. So again, a great need. Almost everybody agrees there's a need for mental health care, but 6 out of 10 are telling us difficult to find affordable providers or insurance covered mental health care providers. The biggest barriers, not covered by insurance, out-of-pocket costs. Those are the biggest barriers to keeping people from being able to access mental health care. Situations that people have faced medical bill for something that wasn't covered by insurance that they've received, 40% say this has happened to them. 32% say they've received a surprise medical bill. Over half of Nevadan voters have been affected by one of those two possibilities, either by getting a medical bill for something that wasn't covered by insurance or a surprise medical bill. Needed to delay care because of out-of-pocket costs. 32% say that has happened to them personally. A majority say that they or someone else that's close to them have had their finances seriously affected by medical bills. Again, 50% saying yes, they themselves or someone they know has had their household finances seriously affected by medical bills in the last 2 years. And of those people, 71% say they or someone they know has seen their medical bills go into collections because of their inability to pay. Turning to solutions, people are asked about what was really going to reduce costs here. At the top of the list in terms of doing a lot to reduce costs, capping insurance companies' deductibles at a level that's low enough that people don't go into debt when getting the health care they need. Second, in terms of, again, this most intense, do a lot to reduce costs, capping the amount insurers can make patients pay for their deductible copays and other out-of-pocket payments. And then the biggest number overall, doing at least a little to reduce costs. Third on the list in terms of doing a lot to reduce costs, but just by a point or two, requiring health insurance insurers and pharmacy benefit managers to pass rebates and discounts they receive from drug companies on to patients. So again, we see a lot of support for those ideas across party lines, as well as allowing the government to negotiate prescription drug prices for those on Medicare, something that is in part of the Inflation Reduction Act that was just passed, Jim alluded to. Strengthen coverage for people with pre-existing conditions. That's also a majority say will do at least a little to reduce costs, but less than some of these other caps that we just talked about. Even lower on the list, the public option so that anybody can buy into Medicaid coverage, require doctors' offices to be transparent and so on. Government-run healthcare system like Medicare for All. We do have significant numbers who say they would reduce costs at least a little, but those tend to be toward the bottom of this list. When it comes to the quality of care in Nevada, over a third think the quality of care in the state is worse than in the rest of the country. Only relatively few, just 12% say it's better. 44% say it's about the same. But again, 35% of Nevadans think their quality of care, is worse than in the rest of the country. Indeed, we asked this question last time around, and we got very similar answers. But 40% say that if they became ill, they could imagine a number of situations where they would want to go out of state to get the quality of care that they needed. 47%, only 47%, less than half, feel confident that if they became ill with almost any disease, they could get the quality of care they needed in the state. Among people who have health issues, the numbers are a little worse, which is to say only 44% think are confident they could get the quality of care they needed. 44%, the same number, think they would have to go out of state to get the quality of care that they needed with at least some set of diseases. People are finding it at least somewhat difficult to get a primary care appointment and have to wait over a month. 38% say it's at least somewhat difficult. The same 38% have had to wait a month or more for an appointment with a primary care doctor. When we ask about specialist care, the people are evenly divided over whether it's easy or difficult to get an appointment. 47% say it's at least somewhat easy. 46% say it's at least somewhat difficult to get that appointment for specialty care. 41% have had to wait a month or more for making an appointment with a specialist. So let me stop there and turn it back to Peter for the panel.
Titus. Dr. Titus was a practicing physician for many years in Lyon County who served as chief of staff at Lyon County Hospital and on the State Board of Medical Examiners. And I'm betting she's the only person in the room who has run 10 marathons and climbed the summit of Mount Kilimanjaro.
Oh,
I think that's probably fair to say.
I would say so.
Okay, those were good introductions, and thank you guys all for being here. So let's kick off our discussions with an aspect of healthcare costs that was mentioned prominently in the CQC survey: surprise billing. You need a medical procedure, you get it done, then the bill arrives, and you practically need another trip to the hospital to deal with the shock of what you owe. Why aren't healthcare costs more predictable and more transparent? I want to address that question to Dr. Titus, who has a unique insight as a physician and Nevada state legislator.
Well, first, thank you, Peter and the Latin Chamber, for asking me to be on this panel today. I always appreciate the opportunity to share some insight, not only as an elected official, but also one that's involved in healthcare to begin with. That's why I ran for office. My first race was in 2014. And as a family practice doc, I was tired of having to sit for hours on the phone getting my authorization for my patients to get care, and people were making policy that had no invested interest in that other than making that policy. So again, thank you to all. So we have in the legislature worked several sessions now to address that surprise billing. It affects all of us. I mean, there's not a legislator out there that isn't also a patient at some point. We're all humans, and we all, despite what they say about politicians sometimes, we politicians are also humans, and humans age and humans need healthcare. And that surprise billing is a big issue. There's been bills passed to help prevent that. One of the concerns is, as you or I, we might have insurance and we have an injury. We have to go to a hospital. We don't know that that hospital is not on our insurance. We have to go to that place. So trying to address that so that we can't be turned away. You have to get care. And then that hospital sees you, and in good faith, they should be reimbursed for seeing you. And so there's a quagmire. The insurance companies will say, hey, you didn't go to our hospital, so we're not going to pay for that. And at the same time, the provider goes, well, wait a minute here. I just spent hours with this person. The facility says we just gave them XYZ care at a certain cost, and we should be reimbursed for that. So what happens is it frequently falls on the back of the patients. And I think it's that transparency, which we are lacking. Folks don't know what the real cost of doing business is. And I think more transparency about real cost will be one of the key solutions here.
I appreciate that. If you had to guess how many Nevadans would you say know what a PBM is? I wonder how many that would be. Well, we should all know, actually. A PBM is a pharmacy benefit manager, and PBMs are a major factor in the cost and delivery of medications. Luckily, we have a licensed pharmacist here who can shed some light on PBMs and how they affect our healthcare system. Jeff Stone, this one's for you.
Well, thank you, Peter, Latin Chamber, and colleagues. It's great to meet all of you on the panel, and I'm honored to be in your presence. I've been a pharmacist now for, it's hard to believe, 41 years, owning and operating 6 pharmacies, and I guess you can say I'm kind of prehistoric. My first pharmacy, we printed our labels on a typewriter. A lot of people don't know what that is anymore, but we didn't have anything called PBMs until pharmacies began to be computerized and would start billing for their services. So originally PBMs were called switches. They were basically an intermediary between the patient, the pharmacy, and the insurance, the payer for the prescriptions. And as time went on and technology got better, the PBMs decided to get together, if you will, a pharmacy benefit manager, put staff together and work on behalf of the insurance companies to get better deals for the medications for the numerous hundreds, if not thousands, of pharmacies that are under their contract. So PBMs want to take advantage to of the pharmacies in the marketplace as a bulk group, as a big buying group, in order to garner discounts, in order to lower costs for insurance companies, and hopefully pass those cost savings down to patients. So today across the United States, there are 66 PBMs, but really there are 3 that pretty much have about 80 to 90% of the business. CVS Caremark, so CVS, the chain store pharmacy, they own their own PBM called Caremark. United Healthcare, which has a strong presence here in Nevada, owns Optum Healthcare. And then Express Scripts is no longer owned by any other entity other than themselves. So the 3 of them really control what drugs are put on formularies and what the copays are for the patients. And these formularies can differ depending on the insurance company that is contracted with the PBM for that particular insurance plan. So when they say pharmacy benefit, it really is a benefit in that you have these companies that are negotiating big discounts to try to lower the cost of prescriptions for consumers. When you understand that 47% of the population of the United States got a prescription in the past year. So if there's any close contact between patients and healthcare, really it's the pharmacy that is probably one of the most prevalent and certainly can be one of the most costly. So there is benefits there. But there's also some issues that need to be brought to the attention of patients and insurance companies, for that matter. They have contracts, these PBMs, that are basically you take it or leave it for all the pharmacies. Now, if you're a PBM, one of the top 3 that control basically 80-90% of the market, and you're going to a pharmacy, and the pharmacy really doesn't have a choice but to take that PBM, because if they don't take that one of those 3 PBMs, they're losing a significant amount of business that they can't transact in their pharmacy. So a lot of the contracts that you get with the PBMs are basically take it or leave it. And a lot of it, unfortunately, comes with some very low fees to the pharmacies. And a lot of it comes with what's called a gag clause, a gag clause. What does that mean? So many times you have copays with insurance. Let's say you have a $25 copay and the doctor prescribes a medication, and you may have a generic drug that only you charge $6.95 for the same $25 copay that the insurance is asking you to bill the patient. And if you tell the patient that you have a less expensive drug that they could get, you could actually lose your contract with the PBM, and they can basically put you out of business. So I don't know if many of you know this, but I was an elected official in California. I was a state senator there, and there were many attempts to try to get better transparency and looking out for the consumer when it comes to prescriptions by regulating, if you will, PBMs. And as you can imagine, PBMs are very resistant to any type of oversight, whether it's federal or whether it's state. But there are significant rebates that PBMs will get from drug manufacturers. We're talking in the hundreds of millions of dollars. And we would like to think that those rebates go to lower the premiums for patients, the insurance premiums. And we would certainly like to believe that those rebates would lower their copays and try to make healthcare more affordable. The problem is that there's very little transparency in this area, and there needs to be more transparency to ensure that the muscle power of these large companies, these large PBMs that are getting hundreds of millions of dollars in rebates, are truly being utilized to lower the cost of healthcare for our constituents that year after year are seeing their premiums increase, seeing their copays increase, and in many instances seeing the scope of their insurance decrease. So that is going to be a struggle that we will have in the legislature here in Nevada in the year and years to come, is doing our best to making healthcare affordable, giving the best possible quality healthcare to our constituents. But we need to work closer with our PBMs to make sure that the benefits that they're receiving, they are now multi-billion-dollar companies that are not just making money just because they're acting as a switch, an intermediary between an insurance and a patient. They're actually making money on rebates that are coming from drug companies. And that goes along into the way they construct their formularies too. I'll give an example. You may have two drugs that are used for lowering blood cholesterol. Mevacor is a brand name of one. Atorvastatin is a generic name for another. So you may, and what these PBMs will do is they will pit a couple of different companies against each other that have the same pharmacological class of drugs, and whichever one gives the better rebate is the one that probably ends up being higher on the formulary, even though the one drug that gives the higher rebate might be the more expensive drug that ultimately the patient has to pay more for. So there really needs to be a patient's bill of rights, if you will, that ensures that when PBMs work out deals with drug companies for the benefit of lowering costs, that those costs truly are reflective in lowering premiums and lowering copays and having more inclusive care for a lot of the patients that reside in the state of Nevada. It's just interesting that as I hear the other topics being discussed, it's like hearing the similar issues that it's not just happening here in Nevada, my friends. What you're hearing with surprise billings and things like that, those are issues that have been addressed while I was in the legislature in California. I look forward to bringing some of that wisdom to Nevada to make things better, easier, better healthcare, and less expensive healthcare for our valued constituents. So I hope that answers.
It sounds like we got a lot to digest there, my friend. Lots to digest there.
Happy to help in any way I can.
Back inside here. I appreciate it. That was great information and very insightful, and we got a lot to digest there. Thank you, Jeff. So one of the most interesting and troubling results of this survey was that most Nevadans feel that our quality of healthcare is the worst in the country. Part of the solution to that has to be our ability to attract, train, and retain good doctors. No one knows that better than you, Congresswoman Berkeley. So, Shelley, enlighten us.
Well, thank you, Peter. And before I discuss the issues that I've been tasked with, I want to say how grateful I am to be a part of this panel. I'm in very, very good company, and I appreciate the invitation. Secondly, of course, I want to thank the Latin Chamber for putting this program on, this panel on. It's very important that the Hispanic community, Hispanic businesses and individuals in our community know about these issues. And the last time I was here, if you recall, it was for the Nevada Donor Network talking about organ transplant. And as usual, the Latin Chamber was in the forefront of helping to educate our fellow citizens on that important issue as well. So I think it's very safe to say that we have a very serious physician shortage in the state of Nevada. Now, I come at this issue in two separate ways. Number one, as you know, for the last almost 9 years, I've been the CEO and senior provost of Touro University, Nevada. We are the largest medical school in the state of Nevada. We are educating and graduating 180 future doctors every year. In addition to that, my husband is a kidney specialist and nephrologist, and my stepdaughter is a primary care physician here in the Las Vegas Valley. I'd like to start with the training, since that's the thing I know the best. I do not believe, with UNR graduating over 60 medical students a year, and UNLV graduating 60 and hoping to go to 120, with Touro graduating 180 students, and God willing, Rosamond will be on board, also serving as a very important medical school for the state of Nevada. We do not have a medical student shortage in the state. we have a physician shortage. So what do we do to hire or to create approximately 2,000 new doctors that we would need to hire tomorrow in order to hit the national average of doctors for doctor ratio to their patients? What that means, and I was very surprised at Melman's numbers that patients only wait about 30 days to see a specialist. In my experience, because I get a lot of phone calls asking me to see if I can't call a doctor and make sure that they get seen sooner, because if you have a kidney problem or a heart problem or any other problem, you don't want to wait 3 months or 30 days for that matter. So what do we do? How do we keep more medical students here in the state of Nevada? We need residency programs. Once you graduate medical school 4 very intense years, you are still not a doctor. You have 3 more years of residency. National average says 70% of doctors end up practicing where they do their residency. Nevada does not have, that's graduate medical education. Nevada does not have enough residency programs to keep these future doctors that we are educating in the state of Nevada, to keep them here. So we, the state with the most desperate need for physicians, are educating a whole lot of doctors to go practice someplace else. So the first thing we need to do, and I have to say under Brian Sandoval, Governor Sandoval, and Governor Sisolak, they have created a graduate medical education fund that the legislature has funded. We need to increase that exponentially. And this way, the hospitals and others can apply for funding to start a residency program. And it's not only the number of residency programs that we have, it's the type. If you are a student and you want to become a cardiologist, and Lord knows we need cardiologists here in the state of Nevada and elsewhere, but if you need that, and we don't have a cardiology residency in the state of Nevada, you must leave the state. And 70% are not coming back according to national averages. So I would say the first thing we need to do is increase our graduate medical education funding so we can create more residency programs so that our graduates from medical schools in Nevada, and many of these kids, they're not kids once they graduate. Many of these young men and women are a product of Nevada. Their families live here. They graduated from UNLV or UNR. We want to keep these people here, but we're not going to be able to do that unless we create these residency programs. So while the training is outstanding, I know Turo, and I'm sure that UNLV and UNR, UNLV, once they are seriously established, we have 100% match. All of our students go on to residency programs. We're very, very proud of that. The other schools as well, they're getting good training. It's just that they can't stay here. And if they don't stay here, they're not going to practice here. So that's the training issue. Attracting, it is difficult for a few reasons. And I know I can't tell you, Peter, how many recruiting dinners I have sat through with my husband's group. There's 33 nephrologists in my husband's group. That's a whole lot of kidney. And they are still out recruiting on a monthly or weekly basis to attract more nephrologists here. That's how serious kidney disease and dialysis is. What is the all of them say, first of all, there's always a little concern about Las Vegas. And I think that's why they bring me along to these dinners, so I can tell them that I grew up here and that it's a wonderful place to raise a family, and on and on and on. But the things that they do talk about, number one is very, very low Medicaid. You're seeing underserved people and you're not getting reimbursed for your efforts. Now, every legislative session, we talk about this and the need to increase the Medicaid reimbursement so that the doctors will see low-income patients. And every year it's determined that it's too expensive, and the legislature, therefore the state of Nevada, can't afford to increase the Medicaid reimbursement. Doctors know that before they come here, and that's one of the things that keeps them from coming. Also, and I think this is an issue across the country, I don't think it's just specific for Nevada, but the malpractice insurance, there's always an issue about that as well. And so it's balancing, what the doctors have to pay, and how you reimburse a patient for a truly catastrophic mistake. And so that's a big issue as well. So attracting doctors, increase the Medicaid reimbursement, figure out what you're going to do with malpractice insurance. And I think that will go a long way to attracting doctors. And also, so you want to keep the doctors that you're training here in our med school. You want to attract doctors from across the country to come and practice here. And the last thing is retention. I don't think that's as large a problem here in Nevada. And I'll tell you why, and I've noticed it from my own students. The fact of the matter is, and that's why the 70% of doctors end up practicing where they do their residency. They graduate, they're in their mid to late 20s. You go somewhere and to get the rest of your training. You're at an age where you're getting married, you're having children, you're establishing roots in the community, you're interacting with the rest of the medical world in that particular locale. So the chances of leaving become more and more remote the longer you stay. So I think when people come here and they see the quality of life, and their children are in schools, and their wives are part of the Clark County Medical Society Alliance, and are getting involved in this absolutely wonderful community, they're going to stay. So I'm not as worried about the retention issue, and perhaps Dr. Greer has a different opinion, but I think it's the training, the residency programs, and doing everything we can to attract doctors from across the country to come to this wonderful community where they are desperately needed.
Well, we always get it straight from you, Shelley. That's for sure.
Too long?
No. That was great, and it was straight to the point. And certainly residency is
Thanks,
something.
Mom.
It's got to be something that. That being said, surprise billing, PBMs. The fight to get and retain good doctors and dozens of other factors are impacting healthcare here and around the country. Joe Greer, what have we not touched on, and what insights do you have on what has been discussed so far?
Well, first of all, I'm honored to be here with the Congresswoman and everybody else that's in Facebook land. And Peter, thank you very, very much for inviting me here. I think this is an incredibly complex, and nobody is left out of the blame game, including us physicians. For example, surprise billing. You go to the hospital that your insurance company says you can go to. The specialists in that hospital don't belong to your insurance plan. Guess what? You went exactly where they told you to go, but you still get a huge surprise bill because that physician is not covered, especially if it's emergency services. Mental health. We talk about mental health as probably the #1 public health problem in this country. 5 years ago, Ann Case, an economist from Princeton, published a paper entitled Deaths of Despair. And for the first time since 1917, the United States saw a rise in morbidity and mortality where no other industrialized nation saw that. Interestingly, it turned out to be non-Hispanic whites of my generation, baby boomers, and the 3 leading causes of death were suicide, opioid overdose, and alcoholic liver disease. Now, if you looked at that curve that went up that way, she does all the morbidity and mortality studies for the country, and there's a flat line from the same birth cohort. The difference was they never went beyond high school. So factors outside of the medical system adversely affect the lives and diseases. Almost 90% of all diseases have a non-biologic cause. We are trained as physicians on how to take care of a disease, not to make somebody healthy. So that type of medical education has to change. I'm really proud of Roseman and its innovation that it does, and the fact that we've been here a couple of years, and being able to produce a unique and different type of curriculum to produce the doctor of the future. It's going to be very different. I'm going to ask everybody here, when was the last time you went to a doctor's office and they did a full physical exam? Can you remember? Because we have all this technology that gives us the same amount of data. So medical education has to catch up with that. I'm also a believer that if I'm in a community as an educator, I have a social responsibility to where I'm at. So we need to reduce, as an institution, disparities that occur, which cause incredibly high prices. We have a system that we've already launched, and we now have 60 families without even having a med school we take care of, called Genesis. We're in the historic part of West Las Vegas. We have another program, which we called Empowered, which deals only with opioid stimulant addicted mothers and their children, to treat them, because that's a niche that was not being treated. And why has that become important? We talk about mental health being so important, but overwhelmingly the majority of mental health providers in this country do not take insurance. They take cash only.
Sure.
So if you're only paying cash only, guess what? That's an expenditure that's huge, especially if you're going weekly or bi-weekly to get some of these treatments. So we have to look at the whole thing. I think the big bad person in this whole thing is insurance companies. I mean,
think we can agree on that.
And
yes.
I also think that I agree with Congresswoman that we need more residency slots. We need more quality residency spots to be able to train the future physicians in the appropriate manner. Even though we have a lot of GME here, last year some positions went unmatched.
Yes.
So we need to attract people to come here and people to stay here. We need to be able to get a system that does not create one of the leading causes of bankruptcy in the United States, which is our healthcare system. And now with inflation going up, they say that if you make $60,000 a year or less, $64,000 being the national mean for a family, 10% of your income goes towards gasoline. And if you're making that kind of money and you work, say, in the city, you can't afford to live there. So your drive is even longer. So all these costs accumulate. And I think we're on the same page. We need to produce more physicians. We got to do something to attract them to stay here. There's laws in the state of Nevada where doctors can have exclusivity in contracts. So for example, if UNLV wanted to right now start a fellowship program in hematology oncology, they can't attract doctors because they can't get any insurance company to pay them, because those contracts are already there. So that limits your ability to bring in people that are going to come here and do where they're going. The Medicaid, I couldn't agree with you more. But let's be innovative. Instead of us just saying as physicians we need more money in Medicaid, why aren't we going to the legislature and saying this is where you get the money?
I'd like to know where you think they're going to get the money. It
Well,
only comes from one place.
For example, in Arkansas, a state that has the highest reimbursement for Medicaid. And that's because they charge 1 penny for every bottle of liquid that's transported through their state, and it goes directly to Medicaid. As a matter of fact, their Medicaid rates are almost equal to Medicare.
That's
So
impressive.
it doesn't have to come out of a business here. But you know what? If you're using our roads and you're hitting other cars in your trucks,
That's very interesting.
you know.
Yeah, that is.
So the idea is for us to come up not just with what do we need, but how do we get there? How do we get there so that our physicians are going to be the ones that stay? At our last institution, we had 35% of our students were first generation college.
Mhm.
Almost 100% came back after training in spectacular places. Why is that? Well, a first gen college student all of a sudden has a few things going for them. They become the first one in their family that can actually earn generational wealth as a professional. We're in the communities right now in the historic West Side, on the East Side here with LIT and some other organizations. And what we're doing is we bring the families with the kids in elementary school all the way through high school and explain to them the return on investment in law education. Roseman also has some other unique things they do at Nevada State. After your third year without a degree, you can apply for pharmacy school at Roseman. And now all of a sudden you get a doctorate in 3 years. And we're doing similar things within our medical school for the master's degree in biomedical sciences, so that these students that are first gen college can't go to their parents and say, "What was it like in college?"
Yeah.
So
So
Yeah,
if I'm
you're talking about me.
so if I'm hearing you correctly, and I like what I'm hearing, is that we got to start thinking outside of the box, even in this industry. We got to think outside the box.
100%.
I like that. So at this point, I want to ask a direct question to each of our fine panelists. What specific first step would you most likely to see taken to move our healthcare system in the right direction? What's the first step? Dr. Titus, I'd like to start with you.
So thanks for that. One of the ongoing, this has been an excellent discussion, and I certainly appreciate everybody's input. I'll concur that the GME, graduate medical education, is one of the keys to the solution and keeping our students here that we train. So thank you, Congresswoman Berkeley, to bringing that up, because I agree. Second thing, which I said, back to your question, Peter, about what single thing is transparency. I use the term transparency, and our pharmacists use the term, Jeff Stone used the term transparency also. And I think the key is single step would be transparency on cost, the actual true costs. I think we can't fight where the costs are until we know what they really actually are and how the insurance companies are mitigating those. We know that you can say, well, we need more money to pay the providers. Well, the reality is right now, Medicare pays about 89% of our cost. Medicaid pays about 59% of the cost. But what the insurance company is getting, and when they reimburse for when we apply. So how does that all play out? So truly sitting down at the table, looking at what their actual costs are. And that's hard to find.
Okay. Jeff Stone, what's the first step?
Well, I think one of the things that's really been highlighted is that if we're going to have a lot more medical professionals here in Nevada, we have to keep residents, we have to have more openings for resident slots, and we got to be able to keep those residents here. It has been shown that 70% of residents will stay in areas in which they're doing those residencies. And so when I was an elected official in California, in a county hospital, we had trouble keeping nurses in our county hospital. They were being trained very, very well. And then they would transfer over to another institution called Kaiser. And we were basically a training ground for nurses for the Kaiser hospital system. And so we came up with a program that said to nurses that wanted to come work in Riverside County that we knew had some significant tuition debt, if you'll agree to work for the county of Riverside 5 years after you graduate from nursing school, we will have some type of a tuition abatement program. I mean, the common denominator for nurses and physicians that are graduating today, and certainly other disciplines as well, is that kids are graduating with significant debt that they have to also take care of. So I would like the state of Nevada to consider some type of an incentive program, a financial incentive program that rewards medical students that graduate from our medical schools here in Nevada that are willing to do residencies here and are willing to stay here and practice after those residencies are completed. We're going to have to find the money to do that, but if we want to have a quality health system here in Nevada, where if you need a cardiologist, you can get a cardiologist. If you want a hematologist, you can get a hematologist. If you need a nephrologist, you can get a nephrologist. And we're going to have to start making some significant investments in keeping the 500 medical students that are becoming physicians in Nevada, keeping them here in Nevada where we really need them. So I'm open to looking at avenues of some type of financial rewards for our medical students that are investing and going to medical school here in Nevada, and finding ways in which we can use those incentives to keep them here in perpetuity so that we can enhance our healthcare systems here in the state.
Excellent. Thank you so much, Jeff. Joe, what's a good first step?
I think I'm agreeing with what everybody says, but to reduce cost, you have to be able to manage these insurance companies. Doctors have to be paid appropriately, as do the nurses, but you do need to start with that step. The other step I think that's real important is the physicians and keeping them here. There's a few other data points that are important. Fewer than 500 students a year from this entire state of Nevada actually apply to medical school. So we have to start recruiting at a much younger age to get students. Why is that? Well, with our experience is that you get somebody from here, it's easier for them to come back. Because we're a long ways away from producing the number of cardiologists and gastroenterologists and hematologists that we need, because it's not just a matter of getting residency slots. These are called fellowships. Fellowships are dependent upon your initial residency. And for example, if you don't have internal medicine, you cannot have cardiology. You cannot have oncology, hematology. You cannot have gastroenterology, nephrology, et cetera, unless you have a surgical program. You can't have those either. So these are all requirements from the ACGME that oversees what's going on. You will be producing a lot of primary care doctors, but they need a place to be able to study in their fellowships. You have some great fellowships here. I'll tell you right now, I am, as a gastroenterologist, hepatologist, I am super impressed with the fellowship in gastroenterology here. They're incredibly academic. They publish. They're great clinicians. As a matter of fact, one of my former students from the East Coast is now doing a fellowship there. And so, and I have no problem referring everybody and their brother there. So we need to do that. Transparency. There's only one transparent, completely transparent system of healthcare in this country, and it's called Minute Clinic. That's the only place where you actually see the menu and what they actually charge. And this is what we do, and this is what we charge. No hidden costs, nothing else hidden. It'd be nice that every time you went to a hospital and to a physician or something of that nature, you got a menu. And by the way, these are your sides, and this is what they cost. But I mean, I think that collectively, these things all have to be done.
Okay, great. Shelley, we have a few minutes left. Let's talk about first step. What do you think?
Wrap it up. Okay. I agree with Dr. Greer when he says that we need to start encouraging our youngsters to seek a medical career, not necessarily a doctor or a nurse. Physical therapists, occupational therapists, physician assistants. My school has them all. And there's a tremendous shortage in the state for all types of healthcare providers. We have a mini med school that we send our students in their white coats, very impressive, stethoscope on the neck, and they go to elementary schools. And they let the kids hear the heart, and it works. It gets them excited, and they start thinking about a career in medicine. And you're so right. So many of these youngsters don't. My father was a waiter. Anything about law or politics or anything, but I was exposed to it at an early age through my school, and that's what got me excited. And I'm also a first-time college goer. No one in my family ever went to college. Turned my family around when I did, and that makes a big difference. I'm running, I think you know, and I know Peter knows, I'm running the Turo here in Nevada and in Northern California. So I'm dealing in California as well, and the challenges are.
Sorry about that.
Yeah, it is a challenge, Peter. I so am happy when I come home. But the fact of the matter is that we do need to figure out a way to entice people to go into the nursing profession. I can tell you our nursing programs, they're burned out, especially after COVID. They're not paid adequately for what they do. They are burned out with 12 to 15-hour shifts. They've had it. And they think, why would I do this when I can sell real estate and have a little bit of peace of mind? Although you do real estate, not so much peace of mind, Peter, but I think that's important. Legislature, unless you're going to prepare the legislature and figure out, I think it would be wonderful to subsidize all the med students. Where are you going to get money to do that? And this is a low tax state. Nobody wants to pay taxes, and not businesses, not individuals, not our seniors, not our young married people. So unless you get a consensus and people decide that the medical education and training is paramount, you're not going to get these additional resources from the legislature. It sounds great. And Dr. Stone, I so agree with you about the need, but I served in the Nevada state legislature starting in 1983. We haven't been able to do it since then. So one other thing I have to say, Peter, I think the quality, there's tremendous shortages and there are a lot of problems in healthcare, not only here in Nevada, but throughout the United States. I have to say, I think the quality of care in this state is as good as any other state. If I was sick, I would stay here and be very confident that I would get the best of care. So I don't think people should worry so much about that. I think it's no different than the challenges that every other state is facing right now.
Well, I think that was an incredible way of ending this. I want to say in closing, the quality, accessibility, and expense of healthcare today impacts all of us.
Yes, it does.
The healthcare system in its current state is not meeting the needs of most of the people who are relying on it. But I'm encouraged. I'm encouraged because there are so many great minds and dedicated people and organizations working to make it better, working to make it easier, working to make it more affordable. Those people and organizations include our guests and panelists here today who at a minute's notice show up when asked, and we appreciate that. So I want to say thank you, Jim Manley and Consumers for Quality Care. Thank you, Mark Melman, for gathering the data which we are going to send out to produce a clear picture of the public's impressions of healthcare in Nevada. That's important for all of us, as you can imagine. And on behalf of the Latin Chamber of Commerce, thank you to our distinguished panelists, Congresswoman Shelley Berkeley, my friend Dr. Joe Greer, Jeff Stone, and Dr. Robin Titus. And of course, lastly, thank you to everyone who has joined us here today, either live or virtually. Your attention is very much appreciated. And this chamber will continue to bring quality things like this to you. Yeah, we're a chamber of commerce, and people will say, well, you should be focused on small business. And trust me, I am every day and every night. However, healthcare affects all our businesses and affects my members and my community. And so we'll be bringing more of this because I think we need more of these discussions. So thank you, everyone.
Thank you,
Thank you.
Peter.